I know I can get answers. I know that the guidance I receive is sound, and if it isn't working, then when the palliative care individual comes, we can discuss that, and we do.
The Centers for Medicare and Medicaid Services, or CMS, designed the Medicare Care Choices Model, or MCCM, to test whether offering eligible people with Medicare the option to receive some supportive and palliative care services concurrently with other treatments would improve their quality of life and care, increase their satisfaction, and reduce Medicare costs at the end of their lives. CMS recently finished testing MCCM for 6 years at 141 hospices across the country.
I believe community hospice, their goal in participating with MCCM was to offer patients choice. Many referrals that come in for hospice, patients are kind of at that place of they have to forego treatment in order to receive those supportive services.
We were using palliative care to kind of help with symptom management and then also provide that additional support as patients had a terminal diagnosis or were going through a very difficult treatment.
It didn't happen suddenly and without warning, but it was a gradual recognition of limitations and discovering forgetfulness. It's agonizing to not be able to sum up things that you know well, but you cannot remember.
Over 7,000 people enrolled in MCCM. Enrollees received about 10 visits with hospice staff per month while enrolled in MCCM. The staff often visited enrollees in their homes, where they managed enrollees' pain and symptoms, conducted health assessments, coordinated patients' care, and provided other services.
What I learned from doing this type of work in the patient's home is I realized there's a lot of things that you don't see in the clinic setting.
It was a great help to the caregiver. Caregiver burnout happens a lot. She had so much on her plate that backup from the nurse and the aide was key.
The influence and the benefit goes throughout the family. But if Ms. Penny says it, it's the gospel.
I found that with this program, I had the time to really listen to the patient. I had time to really talk to them and talk to the family members. And it really did provide a lot of not only educational support, but emotional support.
The evaluation results suggest that there was an improvement in the quality of end-of-life care that is more in line with the general wishes of people when nearing the end of their lives.
It really did help catch things early, and I really think it prevented a lot of hospitalizations due to not letting whatever the symptom was progress to a point where it needed to be hospitalized.
For many enrollees, MCCM worked as a stepping stone to hospice.
We found that many of the patients that enrolled in our MCCM program were more open to hospice care as their disease progressed or their goals changed.
The Care Choices to Hospice transition I found was a lot smoother because we were educating from day one. From day one, we were differentiating what palliative would look like and what hospice would look like.
MCCM demonstrated that there is demand for palliative care services among people who want to continue treating their terminal conditions.
With assistance from Medicare, there's no doubt in my mind that many people, many patients, find a way to access such guidance. Otherwise, they couldn't. They would not know where to turn.
CMS is exploring ways of integrating this kind of palliative care into models such as the Accountable Care Organization, Realizing Equity, Access, and Community Health Model, the Medicare Advantage Value-Based Insurance Design Model, and the Kidney Care Choices Model. If you're interested in learning more about MCCM or reading the evaluation report, go to innovation.cms.gov and search for MCCM.